Hello, everyone. Welcome to Room Now's coverage of ACR 2023 and the spondyloarthritis panel. I've convened the faculty who covered ACR 2023 in San Diego and also virtually, and asked them to get together and so we could discuss what we thought were the highlights of the spondyloarthritis content that was presented at the meeting. It certainly was a lot. I want to first begin by thanking our faculty. They were amazing in their output of tweets and articles and great videos, interviews. I mean, it was really astounding. If you weren't following Sheila Reyes, Rachel Tate, Anthony Chan, and Bella Metta, you really missed out. And it's not too late. We're going to be rolling out their content in the weeks to come. But let's begin. I'll ask our faculty to introduce themselves. Rachel.
Hi, I'm Dr. Rachel Tate from West Palm Beach, Florida.
Sheila.
Hi, I'm Sheila Reyes from the Philippines.
Anthony.
Hello, I'm Anthony Chan from London, United Kingdom.
And Bella Metta.
Hi, I'm Bella Mehta from New York.
Okay. All right. So we're going to discuss what we thought were the more interesting, if not influential, abstracts or sessions from the meeting. Let's begin with Dr. Reyes.
Okay, so again, good morning, everyone, from my end. Very early morning. I wanted to discuss about abstract number 2215. So it's from the group of Dr. Mary Marquez. So they wanted to talk about how the validity of rheumatologists being able to diagnose axSpA in patients presenting with chronic back pain. And the objectives of their study were to assess the 2-year prevalence of an axSpA diagnosis. And then they also wanted to explore the baseline differences of patients diagnosed with or without axSpA at 2 years. So data was analyzed from the SpA cohort. So it's the spondyloarthritis caught early cohort, which is the European inception cohort. And so patients presenting with chronic back pain, so that would be more than 3 months, but less than 2 years. And in young patients, and then they were referred to a rheumatologist, and additional workups were then requested. So either imaging on top of HLA, B27, and other SpA features. And so they wanted to look at if at baseline, the diagnosis of axSpA would still be the same at 2 years of follow-up. So out of the 552 patients with chronic back pain, 32% received a diagnosis of definite axSpA at baseline. And then at 2 years, that population became 30%. So of the patients diagnosed with axSpA, so again, about 89% and 87% fulfilled the ACES criteria. Sorry, 89% fulfilled the ACES criteria at baseline, while 87% were diagnosed with based on the ACES criteria at 2 years. Okay, so what they found was that again, baseline spondyloarthritis features were more prevalent, obviously, in the patients that were diagnosed with definite axSpA at 2 years. And they also found out that apart from the clinical features of SpA, HLA B27 status, and sacroiliitis on imaging were the best discriminators for a diagnosis of axSpA. Okay, so they concluded that most patients presenting with chronic back pain can be accurately diagnosed by a rheumatologist at their first assessment. And the likelihood of getting an axSpA diagnosis or definite axSpA diagnosis at 2 years in patients with chronic back pain was higher if they had HLA positivity as well as sacroiliitis findings on imaging. So it well, for me, when I saw this study, well, it just highlights the importance of of doing early rheumatology referrals, especially for young patients presenting with chronic back pain, and how it emphasizes the role or the crucial role of rheumatologists in the correct diagnosis of axpa. We know that okay, chronic back pain may be it's one of the most common reasons why patients come into the clinic, and majority would probably be mechanical in nature, mechanical back pain, but again, an important minority would be composed of inflammatory back pain, and those are the patients that we really want to get a correct diagnosis, because early diagnosis would also confer early treatment and better and improved outcomes.
So Sheila, I don't think that I certainly these are important that let us know that how good we are and doesn't change over time. I think that's important. And I think a lot of us are adept at using those tools to make this diagnosis. But in this inception cohort, did they identify non-radiographic axial SpA and show how good that was over time?
Um, not that they more it's more of the they focused on the diagnosis of axpa, so they just yeah, it's more of the diagnosis of
They didn't
axpa,
split it out.
the
Okay.
accuracy. Mhm.
Anthony, what did you think of this abstract?
I think it highlights to us that the thing that from the study, the thing that is most useful is the early imaging compared to the clinical features, because if you see the study, some of them reverted to become non-expa at a later stage. And those who had the positive MRI findings at the beginning were the ones that remain expa at 2 years. And I think the takeaway from me is that imaging remains the most useful predictor in terms of a future diagnosis compared to clinical features in the early stage. Equally, there were some who with B27 male who were strongly positive for those factors became positive at a later stage.
So I'm a bit of a dinosaur in that I believe in imaging, but I'm just talking X-rays. I seldom, if ever, do MRI on low back pain unless I'm considering non-radiographic axial SpA. What's Bella, Rachel? What's the role of when to go to MR?
I guess I'm still of a sorry, Rich.
No, that's what I was going to say. Go ahead.
I'm still of I think like when X-rays can do the job, why go to MRIs? I mean, when X-rays are not useful or like when they're sort of equivocal or something, that's when I go to MRIs. Plus, I think the big point of this paper I feel is also early referrals. There are patients with low back pain for years before they come to a rheumatologist, and once they come to a rheumatologist, I think like even a good history and X-rays sort of does the job for most of the patients, right? Like MRIs, we do need. I think they are key, but only when these first few don't give you answers.
Yeah, I agree, Bella. I think it's beyond the classification, right? We have classification criteria to give us a little more confidence, but kind of the concept around any type of ancillary, right? Whether that be your HLA-B27, whether that be your imaging, it should support what you already believe from your history. So it just kind of goes to bode with what we've learned about how important our histories and our clinical findings are. And Jack, I'm going to hijack this for just a second because I want to keep talking about imaging. I think it's important. I'm going to actually throw a wrench into what I just said, Bella, because I grew up, my dad's a radiologist. I learned to order imaging. I do STIR and T1 and I follow protocols, whatever protocol my like group, my musculoskeletal radiology team wants. But just to kind of highlight something, so Alexis Ogdi presented Pearls and Pitfalls for the diagnosis of spondyloarthritis. And contextualizing this, she highlighted two things that were important to me. So in the era with the question about should we get MRIs, what should we be looking for? And with these kind of nebulous findings on MRI, and we know there's a consideration for pairing clinical, right, with our imaging. We often think of DISH. So, and you guys all know what DISH is, I'm sure, but just for our audience, diffuse idiopathic skeletal hyperostosis, which I still think is very hard to say at some points in my life. We often thought DISH did not appear to affect SI joints. Well, unfortunately, there's been an update to the guidelines, and it does. It can, in fact, have some changes, right, that we can see on imaging. So we can actually see enthesophytes, we can see bony bridging, and we can see hyperostosis in the SI joints. So this is only to highlight that, yes, if you're getting imaging, it's very important, but you have to pair it with that clinical feature, that clinical history for your patients. What do you guys think about that?
Well, actually, Rachel, I was going to, since you've talked about DISH, um, in one of the poster sessions, it was abstract 1862. So they showed that there was an overlap between inflammatory and degenerative features on imaging of DISH, degenerative osseous changes, and radiographic axpa. So again, going with what you were saying, I mean, we also need to watch out for mimics, I guess, because not all back pain, not all patients presenting with inflammatory back pain is axpa. So we have to consider other conditions, and this is one of them. And based on that study that I've mentioned, the abstract 1862, so they found overlaps when the thoracic and the lumbar spine were imaged. So you really have to it's a constellation of your clinical features, your history, and then your imaging.
But ultimately, DISH and SpA, while they have overlaps, have criteria radiographically that distinguish one from the other. And rheumatologists and radiologists are familiar with that. But since we're in this issue of diagnosis and referral, is anyone going to cover the Spartan recommendations? Was that on your list? Because if not, I'll just briefly mention them. Abstract 0841, Spartan has a draft of their recommendations for rheumatology referral. And they basically, and the problem with these recommendations, it's sort of like a rheumatologist wish list. And it hinged, what they decided on was how many low back pain patients do you have to see, or would you want to see before, and have one of them be SpA? Like, is it 10 to 1? Is it 3 to 1? Is it 2 to 1? And they settled on like either 3 to 1 or 4 to 1, before I'll see. And those recommendations make that a productive consult, because they just don't want to be deluged with lots of back pain. So again, through a process, I guess that was sort of like a RAND process in voting, they came up with you need 3 or more points. And guess what? You get 3 points for sacroiliitis by MR or X-ray. And a lot of the other criteria, the same criteria we have for the and features for axial spondyloarthritis, but that includes 2 points for acute phase reactants, 2 points for B27, 2 points for uveitis, and then 1 point each for IBD, psoriasis, back pain with a response to nonsteroidals, back pain that improves with exercise, alternating butt pain, and a family history. So I think it's a nice idea, but I think it's too self-serving. Like, do you really think what I want as a rheumatologist means anything to the primary care sector or the chiropractor or the orthopedist? They're going to read it, learn it? No, they're not. Not unless you're going to advertise it and strongly make the point. Rachel, you're going to say.
Do you read your own images?
Uh, well, it depends on where I'm working.
That's fair.
Currently where I work, I don't have access to the images digitally on the computer, or I get the reports. But where I worked previously, yeah, I could get the digital or the actually written report and then look at it myself. And when I worked at the university, we could look at the X-rays and make that ourselves. I think I'm pretty good being looking at thousands of X-rays of the SI joint. I think I'm better than the average radiologist who's not a musculoskeletal radiologist. But I do think we need to have better ways of really making that radiographic diagnosis. And AI, all these reports of AI, replacing a lot of people and getting us really accurate reports, especially when you live out there in the middle of nowhere, I think is a good advance. Any other final comments on this, Anthony?
Yeah, I think it's gone the other way with the increased use of MRI. We've also seen a lot of overdiagnosis or overcall. And here at ACR, we've seen some ways of trying to standardize or centralize this. The group from Berlin, they looked at how they could centralize the review of the scans. So they had all these peripheral hospitals sending the scans, and they were able to ensure that they had a correct diagnosis. And some of them were kind of de-diagnosed, if you like, having had initial MRI suggesting SpA, because I think we also come across a lot of people with bone marrow edema from healthy young people. There's maybe pregnancy changes. So while we are very keen to drive the early diagnosis, we also have to be cautious about overdiagnosis or overcall, especially if some of the radiologists may not be seeing these scans regularly.
Yeah, that data from the UK, it was also from the UK, also from Berlin, from Dennis Podubny and his group. I think, but ultimately, these are tools, and you're going to become the digitally enhanced clinician in the future. But you have to make the decision about whether they do or they don't. Rachel, final comment?
One last pearl, because that's really important. Sacroiliac changes. I had sacroiliitis technically. It was osteitis condensa in ilii, right, after pregnancy, but we should not be imaging those patients until after at least a year postpartum. So that's just another pearl to help with that overdiagnostic potential from Dr. Ogdi.
Rachel, any further pearls from that session where Dr. Ogdi was rolling out the pearls?
Oh my gosh, she had so many. You're going to have to go back and look at it, honestly. It was just very rich. My area of interest tends to be a little more, at least when it comes to pearls imaging related. She had lots of pearls regarding other things you should look for, but those are the two that I really wanted to highlight.
Yeah, and the good news is that I think if you were a virtual registrant or a live registrant, you can go back and look at this content on demand. And I believe that session is going to be available, if not right now, in the next few days. So that's a really that's great. I mean, I have tons more learning to do since I got home with this on-demand access. Anthony Chan, what was your highlight at the meeting?
So, mine was abstract 0775. And this is a tapering study called the SpA study from the Netherlands. And this is about tapering with a treatment to target approach in both SpA and PSA. There was the data from, we heard about Arctic Rewind from the rheumatoid group, but in the SpA group, this was quite a nice study. So they had two groups. One was clinically driven and one was protocol driven. At 1 year, the daily defined dose for TNF, the DDD, was 52% in the protocolized group, whereas it remained very high, only at 77% in the clinical only group. So but they both achieve a low disease activity despite the kind of most stringent tapering in the optimized group. That shows that it's possible to dose taper, but to follow a protocol and to ensure that the patients are not flaring. But when they went back to, when these patients in the optimized group were reverted back to clinical decision making, then there was a dose escalation again in the 12-year extension. That group went up to 66% from 52%. This shows that if you are to dose taper, we have to do it in some protocolized way where the patients are monitored to ensure that they don't flare up. But it is possible to keep them in low disease activity and to reduce their exposure to TNF in the long term. So that was my my kind of takeaway from this study.
These tapering studies have interest. I must say they drive me crazy because I'm totally against it, and there is evidence that people get worse. And why would I spend my whole career trying to control these diseases only to allow them to get worse because of my neglect or my lack of guidance? But nonetheless, there's a reason to taper, and one, it's a financial reason, right? I mean, I think for jurisdictions that have to pay for this money and they'd like to know if they could save some money, it makes sense. The second reason is the patient taper, meaning they're going to taper whether you want them to or not, and being able to guide them makes sense. And the third reason would be the physician-driven taper, and that's a special kind of crazy that I'm not joining that group. But good luck if you are. The good news is there's papers like what Anthony's pointing out and others that that will support you. But then there's also those same papers will support me in saying, this is not a good idea. So anyway, what are your views on tapering, the rest of the panel here?
I think like patients do it, as you said, whether you want it or not. If you sort of guide them through, maybe you'll know the answer or you'll know what they're doing. But especially in the US, you don't know if you've prescribed a medication, if they've picked it up, they've taken it. I think there is a few patients who are early and you've got them into remission. I do support taper, but others, I'm a skeptic too. I don't want to just start tapering like even when you start a patient with a biologic or something, the first question they ask you is, how long do I need to take it? Even though they're like flaring, like, at least you say, let's see it for a year or two and decide. But that's the first question. So we have to listen to our patients.
I agree. Rachel?
I think go ahead, Sheila.
Go ahead, Rachel. Go ahead.
I mean, I'm going to just echo that. The only thing I will add is that sometimes, as you mentioned, Bella, patients taper not because they want to, but because it just happens, right? Some of the dosing schedules aren't always easy for a patient to remember. Did I take this every 2 weeks, et cetera? But one thing to consider is I've seen too many flares, and I've seen too many patients with the inability to recapture. And that makes me worried that if we are tapering for these patients, that we will have disease progression, or we will have the inability to recapture those patients. And so I don't taper.
At least in the RA studies, recapturing is not so bad. So that's, I mean, but I don't know. I think that I've seen exactly what you said, Rachel. I want to go ahead, Sheila. I want one final point on this, but I want to hear from you first.
Yeah, so I also agree with what you said. For example, in our area where most patients pay out of pocket, so it's actually the financial reasons would drive them to, would they would tell the rheumatologist we need to taper, even especially if, for example, they would feel improvements for the first few months, and then they will ask you, can we start tapering, despite you telling them, okay, we may have to go for this medication for a number of years, but then, because of other considerations, socioeconomic and stuff like that. So, but, if I were to choose, I would rather not taper as much as I would, because we see what happens to our patients when tapering, particularly with SpA patients. I think when we taper, there's really the risk of more flares and more difficult disease activities than when the patient started treatment.
So when a patient comes to see you, what happens next has to do with the story that's in their head. What's the story they're telling themselves? And one could be that I trust this doctor, or that I'm going to do everything they say. But all that has to do with whether they're going to follow your instructions and take your medicines and come back and whatever. And this whole issue of tapering or not by the patient is often multifactorial, but is often the patients want to believe I don't really have a lifelong devastating progressive disease. And then you have to play psychologist with them and help them understand over time. In the beginning, you don't want to, really hammer them with that negativism. You want to hammer them with hope and give them some rules and some goals. But, over time, you got to address the fantasies in their head about, I don't really have vasculitis. I don't really have ankylosing spondylitis. I'm just seeing a rheumatologist for a while. I hope I can forget Dr. Chan's name at some point. And that's what this all feeds into. So,
well, I'm just going to add to that just one thought, that there is a lot of, I think for a long time we could sort of control the psychology, but now there's like this huge social media presence that a lot of patients are sort of, most of them are okay, but there's like a lot of quacks on there which sort of feed patients with therapies that are not working. They're expensive, and patients still want to follow it because they believe that this is the cure ultimately. Obviously not evidence-based, and that's something that is scary.
Yeah, it really is. Bella, what's your next abstract?
So I think uveitis and axial SpA, I think that is one of the things that I sort of sometimes don't think about too much initially when I see patients, and obviously is a huge problem. So this is abstract 2550, which is a systematic review and a network meta-analysis of 43 studies. They pooled around 9,000 patients, which is a lot, either on biologics or targeted synthetics. And they looked at incidence rates of anterior uveitis in these patients. And what they found was, anti-TNFs, except etanercept, work well, sort of to prevent uveitis. So it was like 1 per 100 patient years of uveitis in anti-TNF group. In the JAKs, it was 1.4, so still pretty low. IL-17 was 2.2, etanercept was 3.2. So as we all know, etanercept probably doesn't penetrate the eye as much. And then the placebo group was 4.3. I think the biggest takeaway is that the anti-TNFs and the JAKs sort of are better at preventing anterior uveitis.
What did you think of the abstract 2548 about uveitis rates with bimekizumab? Looking a little better than the other IL-17s. It wasn't a head-to-head comparison. It was just a rate analysis of what they've done in their development trials with a few thousand patients. Does that make you think that maybe you would use this dual inhibitor of 17 in patients with uveitis?
I think so, because I think IL-17 is not too, but I still, I think like we know that TNFs do a better job with it. So especially these sort of things, maybe if if on TNF failures, maybe that's when I would go to it, because JAKs, I think like at least the New York patients are very skeptical about it. It's been tough to sort of push it down. Like the patients are reading all kinds of things. Like I said, like social media or whatever, like there's too much influence, I feel, for patients to pick up drugs.
Yeah, Anthony, where should we stand on IL-17 and uveitis? Oh, had this Rachel,
He
where,
didn't. No, he's like,
Wait, he's coming back. I'm
Apologies.
sure he's got an answer.
We had a change. Sorry.
Technical difficulty.
Yeah, sorry, in the hospital. Apologies for that. My feeling is that they don't make uveitis worse, so that this is the background. A lot of this is the background risk of the SpA itself, rather than promoting or making the loss of control. TNFs would be still very much first line, and I think JAK inhibitors are increasingly getting into a good position there as an alternative should the patient not respond to the TNFs. But my feeling about IL-17 is certainly not any worse. This should reflect the background risk of uveitis.
Okay. All right, so we're going to do another round. Let's do shorter presentations and shorter discussions. Rachel, why don't you begin?
Well, Bella just mentioned that we have influence, right, with social media. So we actually have a celebrity amongst us right now. So I am actually going to defer a little bit. I'm going to set the stage, but I want Dr. Anthony Chan to give us a little bit of an update on abstract number 1410, which was actually his abstract that I was able to go see him present at the poster. So Anthony, can you tell us about this delayed in diagnosis?
So thank you. We highlighted earlier about the Spartan criteria, but in fact, we go back to the ASAS criteria. ASAS in 2016 published a set of referral guidance to help us define and detect SpA a bit earlier. And we have used that around 2017 as an electronic tool where our primary care physicians, when they type back pain into the referral, it pops up and it gives them guidance as to when to refer patients. And these are patients who have inflammatory back pain for more than 3 months, below the age of 40, and then they have one of a host of other criteria. And when you get to about 3 or 4 of these criteria, this makes it very likely that eventually they will have SpA, and then they would come to our clinic and we're able to then do the MRIs, scans on them. And over this time, we have managed to reduce our delay to diagnosis, what we started off being 8 years. In the last year, we've managed to get this down to 1 year in terms of the symptom onset to the time of diagnosis. We find that we are picking up both radiographic and non-radiographic patients, and the male-female ratio is really 1-to-1 in this cohort. So it is possible, but then this needs to be followed up with training and education. It's good enough having the referral, but we need to explain to our primary care physicians how to actually apply the referral guidance so that we are not finding ourselves seeing a lot of mechanical back pain. And we've doubled our accuracy rate from what used to be 1 in 3 to now 2 in 3 of patients turning up to our clinic with the correct diagnosis.
So these are diagnoses by the primary care sector using knowledge that you have afforded them?
So these are diagnosis by secondary care and by the specialist eventually,
Okay.
but they are suspected when they see them in primary care, and they apply these guidelines, and then if they meet a certain threshold, they get referred to our clinic. And we have found this quite effective as a way to try to streamline the referrals better into our clinics.
Do you think this is something that NICE will adopt, your National Health Service?
Yeah, so it is in the NICE guidelines. The issue, I think, is about the training and the implementation of these guidelines. And we have spent the last 2 to 3 years trying to educate our primary care physicians more about SpA. Nationally in the UK, it's 8.5 years. We have kind of tried to reduce that now down to a year.
That's excellent. Rachel, what do you think of this?
No, I mean, I thought this was one of ACR best. I really appreciated the concept of a population level that you guys put a lot of approach to. And what I really found to be just hopeful, I think, is that although this is in a nationalized healthcare system, these are tools we could all use for our own referral base. But taking this down from 8 years to 1 for both non-radiographic and for SpA, I mean, that's admirable, and it's really commendable. So I knew you weren't going to bring it up, so I wanted to.
Yeah.
I mean, that's a game changer. Like
Yeah.
from 8 years, because it's not just the 7 years that you sort of diagnose early. It's like the future of the patient, right? Over the next few decades. So that's great.
And it's key that A, someone studies it, B, that someone shows that you have a better way, and the C, it becomes common knowledge and or part of the system or built into the EMR or whatever. So I think for many, many years we talked about earlier referral of RA, and I think we believe that we did it, but I think that a lot of that was common knowledge without real effort, and still referral of early RA is not that great in the United States. And I think you could certainly lead the way with SpA. I think in many ways it could be easier to refer if these 3 points or whatever you want to hang your hat on as far as education. Great effort.
Thank you.
Sheila, what's your next one?
Okay, so my next one is abstract number 1402. So the investigators here just wanted to determine whether AxSpA patients in their cohort, or in their clinic rather, this is from Canada, were meeting the recently published Canadian 24-hour movement guidelines. So that guidelines integrate evidence-based targets for physical activity, sedentary behaviors, and sleep quality. And so what the study found out was that in among the patients attending their clinic, participants were highly engaged in physical activity and had less sedentary behaviors, but they had poor quality of sleep. So I think, although the sample size was really small, and again, that would limit a strong conclusive data to be made, but it again brings us to the reality that apart from treatment options, we also look at the quality of life of our SpA patients, and sleep is an important factor. And I think further, like us, sleep is a very important for us. So it affects the quality of life of our SpA patients. And so I think further it can give way for further investigations about sleep patterns, or sleep patterns in SpA, and that could improve patients' quality of life altogether.
Excellent. Any comment on that?
Sleep's important, isn't it, Sheila?
Yes, definitely.
If anything, it'll minimize the secondary fibromyalgia complaints that these folks will show up with, in addition to maintaining mobility and quality of life, et cetera. So, all right, Anthony, what's your next one?
So I've 0776 is the study on IV secukinumab, only because I was interested to see how it would fare in sort of routine use. We know that in the initial PSA and SpA studies, they did use IV secukinumab as a loading dose, and then they would switch to subcutaneous. But here they have a study called Invigorate-2, which is a phase 3 randomized control trial on IV secukinumab in PSA up to 52 weeks, and they gave them 6 milligram per kilogram at baseline and then 3 milligram per kilogram monthly, and this was effective and then throughout the 52 weeks. You might say, why do you do this study? There's already subcu secukinumab. Why do you need to do this? I think it's just important that there might be some patients, maybe a small population, for some reason are not able to self-administer their subcutaneous secukinumab, or there might be reasons for that, and so this is another option, I think, for our patients.
I think this could be insurance driven too, right? Especially in
Yes.
the US.
Possibly,
I mean,
yeah.
I saw this study saying maybe they're doing it so that CMS can pay for it.
It's a lot of discussion amongst rheumatologists about this is a big advance, this is not a big advance. So I'd be interested in your opinions. I think Bella points out that there may be some utility in Medicare patients in the US because then it's covered and it's another option. Rachel, is this an important advance to our arsenal or not so much?
I think it's important. I think that having access to patient care is important. I think having coverage from payers is very important. So as Bella mentioned, I also think it's nice because we do have a few of those patients who we worry about compliance. And this is one area that may be helpful to keep patients more compliant if we're doing intra-office infusion.
Sheila, if this was available to you, do you think there's a subset of patients who you would use this in?
Yes, I think there would be, but I think it's more driven by insurance or coverage of insurance. And I think the only when I came across the study, or when this study started to come out, I was also asking myself, why would they do a IV preparation when subcutaneous, in terms of convenience, is really convenient for the patient. But I guess, yeah, there are subset of patients who would best, or who would more likely be better with being given IV secukinumab and support from insurance. So yeah, I mean, if you're gonna ask me if this is a big thing, I'm not quite sure, but at least you give the patients other options than just the subcutaneous route.
Yeah. I'm not surprised that it works, right? Like, it will work. The subcutaneous works, so the IV will, I mean, hopefully it's not a surprise, but yes, it's a good sort of option.
Yeah, the other important factor here, Anthony, is that the infusions were 3 milligrams per kilogram, but the FDA approved dose is 1.75 milligrams per kilogram, which they had more evidence of. And the reason it was approved that dose is because they had enough evidence in play that that's what the FDA would approve. If the company wanted to have a variable dose, they're going to have to do more studies and delay the approval. So they went forward. So it's kind of fixed dosing. It's weight-based dosing. Fixed dosing. If you want some variability, you're going to have to go sub-Q or get a letter from your mother as to why they need the dose that the FDA didn't approve. So, okay. Who has another? Bella, your next quick one?
Yes. So this is looking at neutrophils in active SpA. So this was abstract 2233. It's post-hoc analysis for Discover 1 and 2 trials, looking at guselkumab. Again, I think the reason it's important is that they're trying to find other sort of easy biomarkers to predict response. So neutrophils, IL-20, neutrophils, IL-23 is increased in psoriatic arthritis. What the medication does is at week 4 decreases the neutrophil and the neutrophil lymphocyte ratios. And these are things that are sort of being popular. I've seen a few abstracts even in the RA world looking at this ratio and trying to predict flares or fatigue or something like that. So here what they saw was at week 4, all those patients who had low neutrophil counts at week 4 sort of had a higher probability of achieving like BAS-DI20, ACR 50, PAS-DAS, and those sort of patient reported or like outcome measures. Not for enthesitis as much, but for the others. So I just think like it was interesting that this is something that we commonly do and can help with some sort of prediction.
Yeah, neutrophils we don't talk a lot about, but they're the whipped cream on the sundae, meaning they really do all the damage, all the work, all the whatnot, and so I like studies that pay attention to neutrophils. I like studies that use cheap tests like neutrophil to lymphocyte ratio. It's there on your CBC. Get out your little calculator, and when it's above 3, they're not doing very well. When it's 4, 5, and 6, you're going to be in a lot of trouble. I don't care what your disease is. So I think this was smart. I don't know that it'll become a biomarker though. That's for some reason this doesn't get traction when it should. But anybody else think this is a good biomarker or see other good biomarkers at the meeting? This meeting wasn't rich in biomarkers in general. I must say, at least ones that I think that had any traction. I want to bring up the ISER study. I think all of you covered this. The ISER study was abstract 0495. It was a poster. It was a cross-sectional analysis in Spain of over 500 patients, and who had SpA generally. Looks like they were split between axial SpA and PSA. Half were women, and they had 10, 12 years of these activity. They screened everybody with fecal calprotectin, looking for evidence of occult IBD. And they found a surprising number, like with a cutoff of 80, they found it in about half of the patients. And then they used that as a next step reason to either do capsule colonoscopy, but most of them I think got real colonoscopy. And in the end, they found 4.4% who had IBD. So on one hand, it's a big study to find a few patients. But along the way, in between that 4.4 who had definite IBD, there was a whole bunch of people who had colon abnormalities on colonoscopy, which were like, maybe these people evolve. And so I think it was worthwhile because they're now in the hands of the gastroenterologists. And if they find abnormalities, they're going to be following up on abnormalities. And we think that they're going to be maybe a little bit better in finding IBD. And the important point here is the vast majority of these patients didn't have GI symptoms. Some of them did. So this is a fairly new story in the last year or so that of occult IBD occurring, and in fact, I want to even really get into a crazy tangent right now, and that is IL-17 inhibition causing colitis. When I've had that happen in my clinic, that colitis didn't go away when I withdrew the IL-17 inhibitor. Meaning, I think that pushes people who have pre-existing colitis to fully manifest their Crohn's more so than ulcerative colitis. And we know this whole subclinical colitis story back from the days of sulfasalazine. So anybody have any interesting comments or further comment on the ISER study?
I just think it highlights that we need to keep asking patients questions, because even though there were patients who maybe didn't have inflammatory bowel symptoms, family history, there were a lot of contextualized questions that we need to know more, and we need to be following these patients a little bit more closely in terms of the spectrum of disease.
Yeah.
Yeah, I think it's really important to screen these patients more carefully, especially when we are choosing therapies such as IL-17. NSAIDs themselves can also raise fecal calprotectin, so that also needs to be evaluated in the context of all the decisions we're making for our patients.
So do you regularly do fecal calprotectin on all patients?
No,
I do it in patients who,
go ahead, Anthony. I'm sorry, you have experience.
I do in patients who are symptomatic. A lot of them have been labeled as irritable bowel syndrome, IBS, but in fact, we do find that some of them do have raised fecal calprotectin. We refer them to our gastroenterologist before we choose any therapies that might affect their gut.
And what I heard at the meeting is a lot of people and even GI people are saying that fecal calprotectin is ultra sensitive, and you'll find a lot of abnormalities that you don't necessarily want to chase down. And so the natural question is, well, then what is the screening tool? And I think what I've gotten out of this, I hope maybe you might have a different one, is awareness is the screening tool. Being worried about this, and as Rachel said, asking the questions at each visit. Do they have GI symptomatology that you can, say is not due to their medicines like nonsteroidals, and then having a high index of suspicion and a low threshold for referral. So I think that's the best you can do. I'd love to have another good screening test like fecal calprotectin, but I don't think we have one. So, all right, let's say if we can, let's end with one abstract number and a one-liner to make the audience think, oh, that's the one I should take a look at. So can you give me a abstract number and a one-liner about why the audience might look at it, and then we'll wrap up. Sheila, do you have one?
Okay, I have 2547. It's the characteristics of difficult to treat axSpA. Of course, we don't have specific set of guidelines yet, but in that paper, they found that patients with longer disease duration, peripheral involvement, higher BASDI levels at baseline, and fibromyalgia were associated with difficult to treat
Okay,
axSpA.
too much. I just want when you said difficult to treat axSpA, you had them. Either they're interesting or they're not. Rachel, do you have one?
I'll just bring forth one that Sheila had commented on previously, not in this session that we're talking about, but abstract 0516. Just remember that the expectations for axSpA may differ between patients and physicians.
Patient perceptions. Anthony.
Yeah, I was looking at 1690. We got some information on apremilast, a drug that we've used quite a lot in the past, but lacking a lot of structural or imaging data. It was presented as an MRI data, which is quite useful in terms of making some of our treatment decisions.
That's the foremost study, right?
Yeah.
And then Bella, you have last say.
So abstract 0844, this is showing that, where the inflammation is where the ankylosing happens. So facet joint inflammation is rare, but when it's present, that's when where ankylosing happens. And they show it very beautifully in MRI data.
Excellent. I want to thank our faculty for all their hard work in the last 5 or 6 days. Actually, they've been preparing for weeks ahead of the meeting, studying the abstracts and making up their hit list. You did a fabulous job in highlighting the content from this meeting and reviewing it here today. That's it. I want to tell the audience to tune in and look at more of these topic panel discussions. We have them for RA, for lupus, for PSA, and also for JAK inhibitors as well. So look for those either as videos or podcasts. Take care now. Bye-bye.